Hello, bonjour, and welcome to this public webinar offered as part of Healthcare Excellence Canada's program, Sparking Change in the Appropriate Use of Antipsychotics. The program aims to support long-term care homes across Canada to improve the appropriate use of antipsychotics through person-centered care. Registration is still open, so if you are a long-term care home in Canada, you're welcome to join us for further quality improvement supports, coaching, and financial award opportunities. My name is Nicole Pollock. I'm a senior program lead on the Health Innovation Programs team here at Healthcare Excellence Canada. My pronouns are she, her, and I'll be your host for today's webinar. It's great to see so many people joining us today. I'm sure the whole country stayed up past their bedtime last night watching the federal election results. So thanks so much for still showing up here. So we are pleased to offer French simultaneous interpretation. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point during the webinar in English or French by typing them into the chat box, and then we'll address as many of your questions as possible during the Q&A session near the end of the webinar. If you need support at any time, please reach out to our tech support using the chat feature. This session is being recorded, and the recording will be made available in the coming days through our YouTube channel, which will be linked in the chat, and it'll also be posted on our website within a few business days. So I want to start by acknowledging that I'm joining you from my home in Ottawa, which is the traditional and unceded territory of the Algonquin Nation. I recognize and appreciate my ability as a settler to live here with my family. Healthcare Excellence Canada is also located in Ottawa, but with staff all across the country. HEC honors the traditional territories upon which our staff and partners live. I invite you to share who you are and where you're joining from in the chat box. So a bit about Healthcare Excellence Canada. If you're new to us, HEC is a not-for-profit organization funded by Health Canada. We collaborate with diverse people and organizations across the country to spread innovations, build capability, and catalyze policy changes that improve healthcare safety and quality. And I'd like to thank and acknowledge our supporting organizations who are continuing to help us promote this program and review award submissions. The objectives of today's webinar are to review deep prescribing strategies, share some deep prescribing tools and resources, address some common deep prescribing myths, and then answer any questions you may have. So I'm pleased now to welcome our speakers for today. Pam Howell is a pharmacist with a Bachelor of Science in Pharmacy from the University of Toronto. She's been with the Geri MedRisk team since 2020, collaborating with specialized geriatric services and supporting older adult care in the Champlain region of Ontario. Since 2018, she's been working with the Deprescribing.org team, supporting their efforts to create evidence-based tools and guidelines to inform opportunities to reduce problematic polypharmacy in older adults. This also includes collaborating with several long-term care partners across Ontario. Prior to that, she had worked for over 20 years working at Briere Health in Ottawa on the inpatient geriatric rehabilitation, complex continuing care, and palliative care units, focusing on medication optimization within an interdisciplinary team. And Julie Weir, you probably know by now, as she is a coach and advisor on the Sparking Change program. With over 20 years of nursing experience, Julie holds a Bachelor of Nursing and Master of Nursing from the University of New Brunswick. She's worked in both the acute and long-term care sectors, with significant time spent working at the provincial level with the New Brunswick Association of Nursing Homes. During this time, Julie led the provincial scale of several quality improvement initiatives, including the appropriate use of antipsychotics and the implementation of the InterRI LTCF. Julie currently serves as the president-elect to the board of directors with IPAC Canada and as a professor in the Faculty of Nursing at UNB. Julie continues to work with HEC as a coach for several initiatives and is one of the long-term care co-leads with Choosing Wisely Canada. So once again, please feel free to drop any questions you might have into the chat box throughout the presentations. And without further ado, I'll turn it over to you now, Pam.
Thank you very much for that very nice introduction. And I also want to thank Healthcare Excellence Canada for giving us the opportunity to speak with all of you today. We're very appreciative for the chance to talk about the deprescribing.org work around antipsychotic use and deprescribing in long-term care. Next slide, please. So to start, I wanted to give a bit of background about who we are and what we are about. So the Deprescribing Guideline resources and related research began in about 2013. They were co-led by Doctors Lisa McCarthy, Wade Thompson, and Barb Farrell. With their clinical experience, they were seeing the growing impact of medication burden and the expressed gaps in knowledge by their colleagues about how to appropriately manage these situations. It's really what formed the basis of the deprescribing.org team mission and goals that you can see here. Work has involved developing rigorous methodology for constructing evidence-based deprescribing guidelines, as well as creating related tools that are now used worldwide and are freely available on our website. These guidelines and tools have been endorsed and used by numerous organizations, including the support and partnering from Healthcare Excellence Canada as part of their Sparking Change in the Appropriate Use of Antipsychotic initiatives, which is why we're here today. Ultimately, what drives us at deprescribing.org is improving people's well-being. I know many of you are like-minded in that way, just by the virtue of the fact that you're here today. Next slide, please. So just to set the stage, to let you know what we've learned along the way since 2013, our team considers deprescribing as the planned and supervised process of dose reduction or stopping of medication that might be causing harm or no longer be of benefit. Deprescribing is part of good prescribing from what we consider it, and it's backing off when doses are too high or stopping medications that are no longer needed. There's also two other points that are important to keep in mind when talking about deprescribing antipsychotics that I'll plan to explain a little bit more later on. But in general, the first is that we've learned that deprescribing a medication has the most success when you lean in as a team. And I don't just mean the prescriber and the pharmacist or nurse. In my own hospital pharmacist experience, I've relied heavily on non-drug approaches offered by my colleagues like physiotherapists or occupational therapists or dietitian colleagues. And just as with prescribing of medications, involving the person or care partners in deprescribing decisions is key, as they're a pivotal part of guiding what might be the best option for them, especially when more than one best option exists. The second point I wanted to kind of highlight is that we've been fortunate enough to collaborate with many long-term care partners, both in the homes themselves and across Ontario, with organizations representing healthcare providers, administrators, residents, and family care partners. Their message to us has always been, we are a motivated and poised group to deprescribe, but we would really welcome tools and resources to help do it safely and effectively. Next slide, please. What I did want to let you know is that through our guideline development process, we really tried to make sure that there was a thorough way that we were looking at the evidence. And you can see the 8-step approach outlined here that I wanted to just kind of quickly highlight. The recommendations that you'll find in any of our guidelines, including the antipsychotic deprescribing guideline, uses a grade framework, and they're determined by things like quality of supporting evidence, the certainty that the desirable benefits will outweigh the undesirable harms, the certainty in that the values and preferences of individuals are taken into account, and about whether the medication really utilizes a wise use of resources. We then have gone beyond and really looked at what clinicians and other stakeholders like yourselves in a variety of different practice settings, including long-term care, that should inform revisions and also identify key considerations when implementing the guideline into practice. The published deprescribing antipsychotic guideline that you see here incorporates many details as to what goes into deciding if, when, and how to best deprescribe an antipsychotic. What we also heard from guideline reviewers was that implementation would be easier if there was a summary guide and other tools to go along with them. And so that's where our team also created the algorithms that I'm going to hopefully go through with you in the next few minutes, as well as patient tools that also help with the shared decision making. Next slide, please. Just as a quick heads up, if any of you on the line have never visited our deprescribing.org website, any of the tools and resources that I'm going through today are freely available. And so just as navigating our website, I just wanted to highlight here where you can find those deprescribing guidelines and algorithms. Next slide, please. So what you see in front of you here is the first page of our algorithm for the antipsychotic deprescribing guideline. It's probably something that many of you have seen maybe in the past and what most of clinicians are most familiar with. So when you're using the algorithm, it was designed as a stepwise decision support tool, walking a clinician through questions and then considerations once it's identified that a prescribing of an antipsychotic should be reviewed. So it also follows an approach that's been well documented in the literature and reflects many parts of the process that prescribers or pharmacists like myself follow when they're making changes to medications. So on this first page, you'll see that it begins with outlining when deprescribing is reasonable to consider or when caution may be more suitable. So you can see those top three blue boxes that really wants you to answer the question, why is the patient taking an antipsychotic? And then based on that answer, it will hopefully get you to the next level of recommendations as far as what to do with that antipsychotic, whether it's appropriate to recommend deprescribing or whether you should continue it or get other expert opinions through potentially a psychiatrist or other referrals. As far as why the patient is taking an antipsychotic, in particular, the box on the left emphasizes ensuring that symptoms are managed, or answering the question, was there ever any response? The middle box identifies that there may be times when an antipsychotic is prescribed for insomnia. And then the last box on the right outlines indications where it would be appropriate or reasonable to continue with the drug or include a referral, like I mentioned, to geriatric psychiatry. The second portion describes how deprescribing should be done. For example, is it best to slowly reduce the medication over time, or can it be stopped abruptly depending on the indication? The next level of guidance is provided on suggested monitoring parameters during the tapering process and what to do after stopping. Sometimes we go directly to thinking about the worrisome things that may happen when an antipsychotic is removed, like an increase in physical expressions. But what I did want to highlight here is that it's also important to remember that some of your monitoring parameters should include those positive things as well. For example, is the person becoming brighter? Are they more engaged? Are they falling less? Because I think it's also important to highlight our successes when we're deprescribing medications and not just focusing on the negative things. I think these things as well are important in gaining confidence to continue to move forward with stopping and also helping to reassure care partners that you're on the right track. Lastly, the guideline developers appreciated that there may be times when deprescribing may not go as planned. So it was not to say that it was unreasonable to try, but more times than not, there may be other treatment alternatives that can help minimize that risk for harm with antipsychotics, while still making sure that the person's quality of life is at its best. So here you can see those kinds of ideas of if the behaviors do relapse, could you consider non-drug approaches? Should we restart that antipsychotic maybe at a lower dose if it's actually still appropriate, and then reconsider looking at deprescribing in perhaps 3 months' time? As well, if the medication was looked at for insomnia, we kind of look at the alternatives at that point too, if you're noticing there is some kind of a relapse or withdrawal symptoms as you deprescribe. Next slide, please. On the second page, so this is the backside of the algorithm. We do try to provide clinical pearls when deprescribing antipsychotics, things like what formulations of antipsychotics are available that you should think about when coming up with your tapering plan, things like what information have patients and caregivers found useful in knowing when trying to make informed deprescribing decisions. So these could be things like what kind of side effects should we be worried about if we continue the antipsychotic. And as well, there's also further details on what kind of tapering plans and non-drug approaches that could be considered that you would hopefully be able to implement and improve the success of your plan. Next slide, please. So as I mentioned, there's also other tools to support antipsychotic deprescribing in hopes that it will improve the success as far as engagement with other care partners or helping clinicians maybe think through the deprescribing algorithm in a little bit more detail. So as you can see here, we've also developed a short video that is helpful in further framing how to deprescribe antipsychotics using case-based examples. We've developed patient care partner infographics and information leaflet pamphlets that help further explain the risks associated with antipsychotic use in a patient-centered way. And as I mentioned at the start, and as outlined in the two-page algorithm, involving that resident and family care partner is not just a step that should be overlooked. As many of you know, including them in any kind of medication discussions or decisions, including antipsychotic use, can be a really positive way in improving that success. Next slide, please. So in addition to the guideline work, deprescribing.org has been very fortunate to be able to leverage a lot of the expertise and insights from many partners in long-term care in an effort to find other ways to support deprescribing of medications like antipsychotics. So if your long-term care team is putting together an appropriate antipsychotic use strategy, part of your interventions may include things like addressing how to engage and support staff in your project, or how to effectively present the idea of deprescribing an antipsychotic to a care partner. Our research and deprescribing work extends beyond just that of the guidelines, and I think many of the other tools we have available on our website may be of interest to you as you move forward with designing and implementing your strategy. So this work actually started in 2018 with support from our partners at the Ontario Centres for Learning, Research and Innovation in Long-Term Care. As a part of the larger initiative, the Deprescribing in Ontario Long-Term Care project began with a tiny goal. We wanted to create an environment where deprescribing is a sustainable component of medication practices in Ontario long-term care homes. And what we learned was that successful deprescribing in long-term care really required a multi-pronged kind of approach. And a lot of buy-in from many different stakeholders within a long-term care home. And as I said, that team approach is from all clinicians and non-clinical staff, administrators, residents, or their care partners. Thus, we found an approach founded in behavioral science and collaborated with more people than I can mention that looked at how could we identify those behaviors that could make this a reality. As you see here on this slide, we identified 4 different key ideas that helped us realize our goal. And with partnerships with these long-term care experts, we co-designed tools and resources to support 2 behaviors in particular that I thought would be of interest to this group and everyone on the line. They're both about the shared decision-making around medications and the idea that all members of the care team should be participating in deprescribing conversations. So next slide, please. These resources that I'm going to go through next are available as well on our website, and here's just a quick screenshot of our website where you can actually find them. Next slide, please. So Shared decision making is the first one that I wanted to kind of go through because I think it's the most one of the most important and impactful with any kind of deprescribing plan, especially with antipsychotics when people are very hesitant. So it's really understanding the options and reaching choices that fit that person's values and preferences. That best decision for a person can be based on a lot of different things. What the research shows about how different options work, what side effects for them are not acceptable, what that person values as necessary to live a full and healthy life. And these conversations are especially important when you're trying to make decisions where there are multiple options. So, are they more worried about the fact that an antipsychotic may bring back some of those behaviors for which it was started? Or they may actually not even be aware of the fact that there are side effects with those antipsychotics. So engaging them in those shared decision-making discussions can really bring to light exactly what the goals could be and where you might need to support them with more knowledge. Next slide, please. So we co-designed a lot of resources to help do this. And there's a few things here that I've kind of highlighted with the pictures here. And these are just a few examples. They can be used to help prepare residents and care partners for meaningful medication discussions in the hopes that when you finally do sit down with them, they can be the most effective. So they could be trying to get patients to feel comfortable about what kind of questions they should be asking you, the reasons why they should engage in shared decision-making medication questions. Sometimes we found that patients or care partners had no idea they are even part of the team. As well, sometimes care partners feel like they don't even know what different staff help with as far as medications and what their roles are. So we've also tried to develop a tool that can help with who do I talk to and why. And as well, preparing them for what they should be looking to do and engage in, maybe when you're doing care conferences or medication reviews with them. Next slide, please. The other component that we found was very successful and quite imperative is the fact that medication side effects and identifying them are everyone's responsibility. And so some of the tools that we've created are things like a poster that kind of helps highlight to staff and even to care partners that if the resident is reporting symptoms like dry mouth, dizziness, more confusion, that those are symptoms that could be medication related, including antipsychotics. And so they are a part of that care team that should be able to discuss with you that they've seen these kinds of things. And again, who do they talk to and how would they be able to address them with you? And so these tools really try to walk the team through as far as how to support patients and as well other staff to educate them with what they can do to be involved. Next slide, please. Some of you on the call I know are not necessarily doctors or pharmacists. And a lot of the times the question I get from everybody is, I'm not a doctor, I'm not a pharmacist, but, can I still help with antipsychotic deprescribing? And I would love to say that yes, the answer is a wholehearted yes. And that comes along with the fact that all of us have a little part to play in the way that the deprescribing strategy can be implemented and improving the success of it. And so my last part of the presentation is maybe just a few clinical pearls that I wanted to highlight that we have learned at deprescribing.org, and as well a few things that I've learned along the way in my 20 years as a pharmacist. Next slide, please. And these are kind of the key components, that I wanted to leave with you a moment to reflect and spark change in how your role and expertise could support any kind of antipsychotic use project in your long-term care home. And where these clinical pearls come from is that experience that I've had and been privileged to have with an interdisciplinary team, and the fact that there's been many times that I've called on my other colleagues to help me make sure that any medication suggestions that I made successfully led to improved outcomes on less medications. For those long-term care homes where there's maybe potentially a high hesitancy from prescribers, staff, or care partners to deprescribe antipsychotics, these tips might be helpful in improving and moving your strategy forward. So for example, many prescribers worry about rocking the boat or the burden put on them to lead changes by themselves. So implementing some of these tips can make them more comfortable in knowing that care partners are already on board and that staff are willing to be able to, help effectively. So the first one I usually think about is, what is that education component around antipsychotic deprescribing? And that includes all staff, clinical and non-clinical should be included. And, that example could be the fact that as a director of care, perhaps looking at lunch and learns that include all of the staff to come learn about why antipsychotics are deprescribed. And maybe getting some ideas from them as far as how could they be involved and the depth of it. On the flip side of it, I think there's also an education opportunity with the care partners, whether it's through the residence councils or the family councils as well. Consistent messaging has always been something that I think can be very frustrating if it's not there. Especially if a resident or care partner, when they hear from one staff that an antipsychotic has risks, but then from someone else, they might be hearing that maybe the doctor should be increasing the dose because of the fact that, there are more behaviors. So a united front can really build confidence and openness to the possibility of deprescribing. And so one example that I love using is from a colleague of mine. I would go in and say to a patient, oh, I really don't think this medication is worthwhile at this point, and I think it's increasing your risk for falls, or the fact that you're not, feeling all that well. And they would really look at me and think, oh, I don't think you know what you're talking about. And it really, kind of set me back, and I would go back and not think anything. And then my physician colleague about, 20 minutes later would go in and say the exact same thing. And suddenly they would look at her and say, oh, you know what? I think you're right. And that really was the fact that consistent messaging, or the fact that, oh, more than one person is telling me the same thing, really, I think, made an impact on them, especially if they've never heard someone say that a medication could be bad. Starting those conversations about medications can happen with anybody. As I mentioned before, building that foundation right from the beginning, that your team is committed to optimizing a person's medications. So the minute that they are admitted into or moving into the long-term care home, do you say that medications are going to be reviewed? In particular, there could be medications that we want to try to reduce because of the side effects. So that way families and care partners and patients are already ready to, have those discussions with you. And that they're not kind of taken aback if it happens, just suddenly within a care conference and they haven't been prepared for it. And also, I think directors of care, nurses, social workers, family or resident council members could also offer tools and resources to help those conversations. So to already give those people something to think about, to take back and read about, and then maybe come back to you with that feeling that they have the knowledge to be able to have a really fruitful discussion. All of the team members can hopefully help with non-pharmacological strategies. And like I had mentioned, it could be anything from even a physiotherapist, where if you are deprescribing an antipsychotic, are they involved and are able to say, oh, you know what, her balance scores are better. Or I'm noticing that, she's able to mobilize a lot better and a lot easier. So those kinds of feedback and help in monitoring can really be useful. And then lastly, but monitoring, as we had mentioned as well, with everyone there. as far as the team approach. So who else can you bring in to help with that? As far as even family members, letting them know what they should be watching for as you deprescribe and who they should be telling if they notice any changes. And so next slide, please. And so thank you very much for the time. I hopefully didn't go over too much, but looking forward to the fact that we will be having some questions and comments later, and hoping to help out with anything that your teams are looking to implement. So thank you very much, everybody.
Thank you so much, Pam. That was fantastic. As I've been working in the AUA space for many, many years, alongside my colleagues and with the support from HEC. And, I learn something new every time I hear someone speak. But what I continue to be encouraged by is the consistency in the messaging between the different organizations. Pam talked a lot about the interdisciplinary approach and having those conversations early and keeping those lines of communication open, the importance of monitoring data, all the same messages that we continue to support the teams to be able to implement. So, deprescribing.org certainly has many, many tools that many homes have used over the years. You'll know that we as coaches with HEC, we don't tell the homes or even recommend to the homes what tools you use. There are all kinds of tools available to you. Pam presented today on just some of the tools, but we want to hear back from the homes. What worked and why? How did you take this deprescribing algorithm and make it work for your organization? Because we know that every situation, every environment is just a little bit different in different ways. So to be able to adapt and implement a tool in a way that works is certainly a skill. So thank you so much for that, Pam. Fantastic presentation. And I know that many of the teams will use that presentation. Like I recommend to my hub teams, I recommend that you show that presentation during one of your staff meetings. Certainly, the staff will appreciate hearing the message from somebody different, which is always exciting. And again, I've been a nurse for almost 22 years, and I learn something new every time that I hear somebody speak. So thank you so much for that, Pam. So now we're going to talk about, because it's hard to follow that presentation, we're going to talk about some of the myths around antipsychotics. And these are myths that we created several years ago, but still stand true today because the facts don't change. So when we ask, or when we hear families or residents or the general population ask when antipsychotics can help. So antipsychotics may or oftentimes will help to manage symptoms of behavior like hallucinations, delusions, severe agitation, and that's where we get into talking about risk to self and others, and severely aggressive physical behavior. So that can include shouting, hitting, kicking, or biting. That can be very distressful activity that antipsychotics can help with, but in the short term. The intent of antipsychotics for helping with those types of symptoms has never been to put them on the antipsychotic and continue that indefinitely. Next slide, please. So when antipsychotics don't help, or they're unlikely to respond to manage symptoms or behaviors like unsocial behavior towards other people, so not wanting to interact, not wanting to come out of the room, apathy, having no interest in what's happening around them or even in participating in conversations, inappropriate behavior like removing their clothes or sexual advances towards other people, hiding or collecting things, sometimes known as hoarding, repeating actions or words over and over, resistance to a specific person, sometimes that can be a family member or other times it can be a staff member, and wandering or being restless. Those types of behaviors do not respond to antipsychotics, and antipsychotics, the makers of antipsychotics, never claim to be able to fix those types of symptoms or behaviors. Next slide. So there are common antipsychotics that we see. There are some, newer ones that come on the market and don't really stay for very long. But the typical antipsychotic that we see are the risperidol, the olanzapine, the Abilify, the Seroquel, Loxapex. We don't see that as much. Clozaril and Haldol, of course. Those are the common antipsychotics that we see. So one of the myths that we often hear from people who are participating in the AUA or that hear during our presentations at conferences and things like that, the myth is that reactive and aggressive behavior will escalate if we remove the antipsychotic. Staff and other residents will get hurt. So that's a common myth. People believe that the antipsychotic was put on, obviously, for aggressive or resistive behavior, and if we take that away, it's going to come back. And that's actually not what we've seen in any of the provinces that we've done massive AUA reductions in. We've actually seen the difference. The difference is that the behavior either does not change or sometimes improves as the resident is less sedated and is able to participate in their care. There's actually no data when we look at the aggressive behavior scale and the MDS or LTCF. There's actually no data to support that. We've looked into that excessively. We know that Alzheimer's or dementias is a progressive disease, and oftentimes when they experience that behavior that required the antipsychotic, they were at a particular point in their disease process. And then as the disease progresses to involve other parts of the brain, those parts of the brain that cause that reactive or aggressive behavior are now dealing with the disease process. So those aggressive or reactive behaviors are no longer there because that part of the brain has been impacted. So that's why we have to continue to monitor on an ongoing basis. If we start to do a reduction and we get to a certain point and we have to stop, we can't reduce anymore, that's not a failure. We're going to maybe try in another 6 months or a year to see if we can get down to a lower dose, because it's all about reducing the risk as far as we can so that we see a positive reaction. Next slide, please. The next myth is if we reduce or remove the drugs, we'll need to use more physical restraint. The fact is that the data has shown that physical restraint usage usually is reduced. Falls are reduced due to improved mobility, due to less sedation. So we know that antipsychotics are a form of chemical restraint. And when someone is receiving Seroquel twice a day or even once a day, we know that that makes them more sedate. So the result is more muscle mass loss. So they're less steady on their feet. They're less able to walk around. But as we reduce those antipsychotics, what we see is especially if there's a walking program in place. We've seen numerous residents be able to be more safe to ambulate. And some of them have even been able to come out of their restraint because the restraint was only there because they were too confused. And now they're able to be more safe to stand, and they're able to participate in the walking program. So that's another myth debunked. Next slide. The next myth is that it will take more work for staff. We'll need higher staffing levels. So this is, I'll say, one of my favorite myths. I hear it all the time. We don't have time for the AUA because we don't have enough staff. We need more care hours, or we need higher staffing mix. And actually, that's not what we saw in multiple provinces. Antipsychotics don't work for many of the behaviors that they're being given for anyway. Sedated residents have higher care needs. Let me say that one again. Sedated residents have higher care needs. Sedated residents have more wounds. Sedated residents require more assistance with their meals. So they do have higher care needs, and it takes more time to calm someone who is agitated. One upset resident can upset the entire unit, but person-centered care strategies allow staff to be more proactive and avoid reactive behavior from occurring in the first place. So everyone knows I love to tell stories. I can tell you numerous stories of residents who were, I would say, the most impactful activity that we saw were residents who were able to pick up their fork and participate at mealtime. Nobody, I've worked in nursing homes for many, many years. Nobody knows the impact of workload any more than the evening staff at supper time, right? Those residents who require assistance with their meals, or as they have been labeled, their feeders, which I don't like that term, but those residents who require assistance with meals take more time. So when we see residents that are more alert and more participative in their ADLs, who are able to pick up the fork and participate at mealtime, we see staff get engaged because they see firsthand the benefit. Next slide, please. The next myth is that families may not be open to us changing medications, and that's a real concern. We have seen that in multiple provinces where families sometimes, when they're transitioning, especially from the hospital to nursing home, they'll say, wait a minute, the doctor at the hospital ordered that medication. It must be required. So now that we're here at the nursing home, you want to take it away? What are you talking about? But it is an opportunity to partner with these families, to get to know the residents better and provide education about the medications. Anecdotal evidence shows that families are happy, especially when they see the improvements. Residents are more alert, relationships and visits improved when antipsychotics are reduced or removed, and the data shows that residents are more social, and we can see that in the LTCF with the rise. Next slide, please. So we're going to try a little activity. And maybe you don't know what a TRIZ activity is, but this is an activity that actually Cynthia Sinclair introduced me to many years ago, and I use it a lot. So the TRIZ activity stands for Theory in Inventive Problem Solving. And it helps us as quality improvement teams to break away from the lateral thinking to generate novel change. So lateral thinking is, I think along this plane, this is the way I've always done it, so I'm going to continue to do it that way just because that's the way I've always done it, and you get into this perpetual loop. But the TRIZ activity helps you to get out of that loop. It helps you to identify counterproductive things that may be doing and helps you to change. So what we do is we flip a question on its head. So with the TRIZ activity, we're going to ask the question and follow up to Pam's fantastic presentation. How do you ensure that you're avoiding collaboration with your pharmacist? Because, I mean, Pam talked about the benefits of the pharmacist. And so if we're going to talk about this from a TRIZ perspective, we're going to flip it on its head. And I want you to put in the chat, how do you ensure that you avoid collaboration with your pharmacist? And then we're going to talk about it. So I will ask you to go to the chat feature, and it can be just very short, point form. How do you ensure that you avoid collaboration with your pharmacist? And I'll give you just a minute. So thank you, Olivia. You don't include them in quarterly medication reviews. Leslie says, not scheduling medication reviews with pharmacists. Fantastic. Valerie says, by not sharing updated care plans. Neil says, never talk to pharmacists about med questions. There you go. Taylor and Holly say, not asking questions. All fantastic answers. Jay Gallagher says, not include in medication reviews, not asking for the recommendations when you have questions. Excellent. Carla says, not including pharmacists and AUA deprescribing. Wonderful. Leslie says, not following up upon admission histories when resident is admitted on antipsychotics. Lynn says, not trusting the pharmacist's input. I love that one. Not engaging with pharmacists. April says, exclude them from the interdisciplinary team huddles. Wonderful. Cynthia says, lose the pharmacist's phone number and discouraging staff from calling. Wonderful. Lisa says, don't do education with them. Jamie says, do not listen to them and do what we want. Oh, I love that, Jamie. Fantastic. All right. So if the TRIZ activity, and we're flipping the question on its head, tells us, and all the great answers that you put in the chat, tells us how to avoid collaboration with pharmacists. Let's now take a step back and flip those responses on their head and do the opposite. So Karen says, avoid availability of doctors to discuss with them. So if we now flip that using nonlinear thinking, Karen would say, we would make the doctors available to discuss with them. Jamie would say, we'd listen to pharmacists and do what they want. Lisa would say, we do education with them. Cynthia would say, tattoo the pharmacist's phone number on your arm and call them regularly. April would say, include them from the interdisciplinary team huddles and have them at every one. Lynn would say, trust the pharmacist's input. Leslie would say, follow up on admission history when resident is admitted with antipsychotics. So I hope you get the idea between the TRIZ activity and how that can help your quality improvement team to get out of that, this is the way we've always done it, so we're just going to continue to do it. Sometimes in order to be innovative, we have to do something differently. And you can do something differently by asking the question differently and encouraging your team to think, as Cynthia says, not only think outside of the box, but think like there is no box. So I encourage you to do this activity with your staff at your home or your leadership team or whoever you've determined to be appropriate to come up with new ideas, new and innovative ideas, and identify those counterproductive things that you might be doing. With that, I'm going to turn it back over to Nicole and we're going to go to questions.
Amazing. Thanks so much, Julie. I do love both a good myth buster and a good trizz to make you giggle a bit of how outlandish it would be. And it really makes you realize, obviously, we should be doing all of these things. And Pam, what an amazing presentation, all of the guidelines and the practicality that I expected you to share, plus so much more about, how these many resources were co-created and engaging, the whole team and super helpful. And I think there was a bit of a conversation in the chat about that as well. Just saying how you have shown in the past how you engage families and care partners in the deprescribing. So yeah, just wondering as we wait for some questions here, if anyone has any questions they want to add to the chat. Lots of appreciation for both of your presentations, but wondering if you both wanted to comment a bit more about that, about how important the discussion with families, because that is something we've been hearing commonly from teams, right? Where they understand the and have the desire and are trying to implement, and yet there can be some hesitancies from the loved ones who are concerned about the safety and all these other things. So I wonder if you want to speak more to that.
Julie, do you want to
Okay,
go
Pam.
first or do you want me to?
You go ahead.
Okay, perfect. And this comes from the fact that I have been burned, I guess, in the past when I just assume that the decision I am making about a medication is the one that, is the right one, right? And so what we've, continued to learn with a lot of the deprescribing work, engaging a lot of community partners, discussions with family partners and residents in long-term care, is that a lot of the times these conversations have never happened before. And so the first time you bring it up, maybe the first time they've ever heard it. And so it does take that time to build that foundation. And the fact is that, it may take them time to think about it. It may take them time to, come to that realization that you are going to support their loved one with the team approach and gaining that trust. And so these any decision support tool that you do, any kind of education component is only going to help the whole team and the process in the long run. And also being transparent with the fact that they can help with the monitoring, that they are involved with the decision process, and that yes, if something doesn't go perfectly well, which it might not, there are options to still kind of proceed and still be successful without causing harm to their loved ones. So it's really all about making them feel like they are listened to and a part of that process. So the empathy of it and that inclusion for sure.
I wholeheartedly support everything that Pam said. I will just pick up on one little piece that has worked for me in the past, has been, you always have to time the conversation right. The first week that somebody comes to your home and the family are reeling and they're stressed and they're regretting multiple decisions of their life, it's probably not the right time to bring it up. You have to make sure that everybody is settled in first and that you've started to create that reciprocal relationship where you're working together to provide the best care for their loved one. I will say that something that has worked for me is to really engage those families who might be a little bit more standoffish or a little more maybe resistant to anything, not just antipsychotics, but to anything, is to give them a job, to tell them that they play a role here and it's their job to report any changes. And I've seen family members really get involved in the discussions at that point, and I've seen them kind of come out of their shell because they've been so used to going to the hospital and just sitting in the chair and not necessarily having a role to play, to now they're helping. They're doing what they can do to help their loved one adjust to this new setting. And now they feel like they have something to come in for other than just to sit there and stare at their loved one. So that has worked really well for me in the past, and I would encourage others to approach it that way.
Yeah, I love that. Let them know that you're working together towards the
Mhm.
same
Yeah.
thing. And then similarly, a question about what should teams do if they're experiencing pushback from physicians?
Mhm. Mhm.
Tricky within
Yeah.
your own interdisciplinary team.
Yeah, that can be tricky for sure. We need to get our physicians on side. I have had, so I love to tell stories. When we were doing the AUA work in New Brunswick, I went to a grand rounds with all of the family physicians in my region. And I got up to the front of the room, and I'd worked with many of them, like, I knew the majority of them. And I got up to the front of the room, and I always say, you could cut the tension with a knife, and only one got up and left. I thought that was there's 25. I thought that was pretty good. But it was really more about what our approach was. So thank goodness one of the family physicians put her hand up and she said, "Julie, you know what's happening. You know the situation we're in. What would you have us do any differently?" And my response was, "Listen, I know my place and I know my job. I'm not here to tell you you've done anything wrong or you need to change anything that you're doing. My only request is that when you're in a merge and that patient is laying in the bed with a fractured hip and they're all over the place in pain and they've got a UTI and the family are there and the family are saying you have to do something, and you say, well, I can order this medication, but really, it's all I've got in my arsenal, in my toolkit. My only ask is that you would continue that conversation to say, but in 6 months, I want you to ask the question, is this medication still required? Is it still appropriate? Does my loved one experience benefit from this class of drug? And if the answer to any of those three questions are no, then ask the question about deprescribing. That's all I ask of the physicians. I don't ask them to change anything. I don't tell them they're doing anything wrong, because they're definitely, in many instances, it's not that it's wrong at the time of ordering. It's that now we're 3 months, 3 years, or 6 years later, and it's still being given because it was ordered.
Yeah.
So that's my approach with physicians.
Yeah. And Pam, before you respond to that, and we're running out of time here, but a kind of follow-up question, has there been any consideration to doing an AUA presentation or series specifically for physicians or NPs? I feel they need to understand that this is a larger issue and that they play such a big part.
So we haven't particularly done anything with antipsychotics, like in long-term care, like home to home. But definitely, there's always room for opportunities, especially things like this. We always welcome opportunities to do this again. And actually support, like Julie had said, how do we engage those other clinical staff, like prescribers, when the rest of us feel like we don't finally make that end decision, right? And it really is, helpful to understand that all of us feel like we're trapped sometimes, even the prescriber. And so sometimes I look at my role as not only helping them decide how to deprescribe, but really where do I fit in making sure they feel like someone is helping them either monitor, someone has already talked to the family or the resident, and they're already in agreement. So it saves them that step. It makes them feel more comfortable with the fact that they're not just making a medication change and then 2 days later, someone, a family member is going to call them and say, "What have you done?" And that kind of thing. So those little tidbits about playing your team role and taking responsibility for your recommendations to, is helpful for that prescriber.
And I'll just add one little thing, Nicole, very quickly.
Yeah.
When we were working in Newfoundland in 2019, we actually did do a prescriber presentation. Dr. Wilfrey worked with us to do that, and the physicians actually got CMA credits for that, and it was very well attended and very well received.
Excellent. So there was a specific question, Julie, that maybe we can just follow up and share after. I think it had to do with one of your Mythbusters around showing the research behind how the workload is actually lower, and not just after deprescribing, but also during the deprescribing process. And maybe we can follow up with you to get that to share. So we're running out of time here, and we just wanted to quickly wrap up to say again that registration for the Sparking Change in AUA Awards program is still open. Long-term care homes across Canada can register through the link on your screen here. We can link to it in the chat box. You can go to the ATC website, and the program does offer more supports and coaching and opportunities for monetary awards. For example, if you register before June 27th, you'll be entered into our second Kickstarter draw. So you could possibly win one of 30 prizes of $2,000 for your home just for registering, just for signing up. And then you could also submit to the Person-Centered Care Award that is currently open until May 23rd. And there's, again, 30 awards of $5,000 going out to homes. And that is through a draw after you submit. And one final slide, we just wanted to let you know that this is coming up. Care Forward is a new national movement, which does include this Sparking Change in AUA program through HEC, and it's going to focus on 4 key priorities: advancing person-centered care and long-term care, expanding access to care, and easing pressure on emergency departments, helping more people age where they call home, and supporting the health workforce. So you're all invited to join this Care Forward launch webinar happening on May 13th from 1 to 2 p.m. Eastern Time. You can register and learn more by using the QR code on your screen or coming to our HEC website. So lastly, again, thank you all for joining us today. Big thank you to Pam and Julie for their amazing presentations. And I can tell from the chat box that participants found it really helpful as well. And thanks to our webinar producers for making it happen. So please don't hesitate to reach out if you have any questions. You can use the direct email address on the screen here. And before you go, we'd really appreciate your feedback. If you can let us know if this session was helpful, we'll pull up a quick poll to just ask if the webinar provided useful information, if you intend to share what you learned with others, perhaps on your team, if you know more about this topic than you did before participating in the webinar. And lastly, we ask about your gender, which refers to the gender that a person either internally feels or was a gender that you publicly express. And this is optional, but we collected on behalf of our funder, Health Canada, at their request. So we zoomed through. Apologies for going slightly over. Thanks again, everyone, for attending. And this will conclude today's webinar. So have a great day, everyone. Thanks.
Thanks, everyone.